Steps to Becoming a Patient-Centered Medical Home. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for iTenib. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, for those of you who aren't familiar with iTenib, I wanted to share a bit of who we are with you. We've been in business as iTenib since 2003, but we were NextGen users since 1997 EPM version 2.3. We specialize specifically in NextGen healthcare. Our development team knows how to get data into, out of, and around NextGen to customize it and tailor it to meet our clients' unique needs. Our purpose in life, the reason we exist, is to create delighted clients by helping them get the absolute most out of their NextGen software investment. It is our passion to provide solutions for healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. We really do everything NextGen, from consulting to hosting, customization to support, and we have 2 NextGen add-on productivity solutions, ChartGuard and Refund Manager. We're here to help. Next, I want to bring your attention to some of the upcoming webinars we'll be offering. On April 13th, we'll be presenting Quality Care Program Reporting. So many choices, so little time. In it, we'll give a high-level view of the most prevalent reporting programs available and go through what they are, what information is needed to report on them, and where that information can be found. You can either register now on our website or wait until the invitation webinar email from us. And we'll be adding a webinar shortly based on new care guidelines that were released recently by NextGen, so keep your eyes out for that. Okay, so back to steps to achieving a patient-centered medical home. At the end of the presentation, we're going to open the floor up to questions from you. We will answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we will also be emailing links to the recording and a PDF of the presentation later this week, as we do with every webinar. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today, Lindsay Lanning and Kathy Thompson. Lindsay Lanning originally joined us from the Ohio State University intern program, where she was getting her degree in health information management systems. After graduation, Lindsay joined our team as a healthcare informatics coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Kathy Thompson has been with iTenib for 10 years. Prior to joining iTenib, she was a medical assistant at a neurosurgical practice. This is where she got her first taste of NextGen and has been hooked on it ever since. Currently, she is a managing consultant at iTenib, where she specializes in NextGen EHR and incentive programs. Okay, Lindsay, so I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Great. Thank you, Chelsea. Hi, everyone, and thank you for joining us today for our webinar on the steps to becoming a patient-centered medical home. This past year has been a whirlwind of change in the healthcare industry, and at the core of that change has been a shift from volume to value-based care. As this shift takes place, we see more and more emphasis on innovative care delivery models. One that has been getting a lot of attention is the patient-centered medical home, or PCMH. The patient-centered medical home truly is transforming how healthcare is organized and delivered. This model of care delivery that is centered on care coordination and communication also works to reduce costs and increase quality. With this webinar, we hope to leave you with a deeper understanding of what a PCMH is and the steps to achieve this recognition. So in today's webinar, specifically, we will look at an introduction to a patient-centered medical home, defining what this care delivery model really means, what its objective is, and the foundation of a PCMH, and the overall goals of this model. We will then look at the actual transformation into a PCMH, looking at what types of certification and recognition programs are available to practices, and then focusing specifically on one recognition process, the National Committee for Quality Assurance, or NCQA, Patient-Centered Medical Home Recognition, breaking down that structure and identifying the must-have elements. After we cover some of the main practice requirements, we will look at the question, why go through PCMH transformation, and provide common reasons why, benefits to a practice and its patients, but also challenges associated with this transformation. Once we go through this and a practice decides, yes, I want to become a PCMH, they will begin the NCQA recognition process, where we will take you step by step on how to get there. We will point out some benefits of the program, such as PCMH prevalidation, which NextGen has just received. And finally, we will look at PCMH and the future of healthcare. So what does patient-centered medical home actually mean? The patient-centered medical home is a care delivery model whereby patient treatment is coordinated through their primary care physician to ensure they receive the necessary care when and where they need it in a manner they can understand. The objective is to have a centralized setting that facilitates partnerships between individual patients and their personal physicians, and when appropriate, the patient's family. This model is based on providing and managing all aspects of healthcare, with the goal of enhancing care, creating greater patient engagement, and lowering costs due to reducing hospital stays and emergency room visits. Essentially, the PCMH is a structured approach to primary care delivery that stresses putting the patient-provider relationship at the core of all healthcare decision-making. In order to support the entirety of a patient's primary care needs, a PCMH provider develops a team-based approach to healthcare, with an emphasis on preventative services, care coordination, and access to care. So what is at the foundation of this delivery model? Well, 3 things. The first being workforce development. As we work our way through the PCMH transformation, you will notice a recurring theme of team-based care and care collaboration. So workforce development and training is crucial. Second, payment reform. We are in a period of transition toward a value-based healthcare system, where reimbursement is based on quality of care and not the number of services provided. This shift is able to progress through care models like the patient-centered medical home, and continues to do so with the newest push toward payment reform being MACRA, which we'll touch on later. And finally, health IT. Not only is this referring to the actual IT tools used in healthcare, but also health IT quality programs, the main one being meaningful use. There's a ton of overlap between meaningful use and PCMH criteria. Think demographics, e-prescribing, patient communications, and much more. Now the goals of the PCMH. This is what drives the model. And they are, number 1, comprehensive care. Providing comprehensive care by taking into account the patient as a whole person and supporting both mental and physical health with a coordinated care team. Patient-centered care. Taking a patient-centered approach to care delivery by developing meaningful relationships with the patient, their family, and their caregivers that takes into account the patient's socioeconomic and cultural values and preferences. Care coordination. Employing care coordination strategies by harnessing health information exchange, EHR interoperability, and population health management analytics to ensure that patient health information is accessible and usable at all care sites across the healthcare continuum. Ensuring accessibility of care. Ensuring the accessibility of services by offering extended hours, alternative sites for care during emergencies, improving the scheduling process, or making use of technology such as telehealth or home monitoring services. And lastly, focusing on quality of care and patient safety. The goal here is to focus on care quality and patient safety by using evidence-based medicine, clinical decision support tools, healthcare analytics, and best practices to provide a safe, high-quality, satisfactory experience for each and every patient. Just by looking at what this care model is, the foundation it's built on, and its goals, we can tell a PCMH is about so much more than just checking off boxes on a recognition framework. The PCMH is a deep, broad, and challenging commitment to improving the lives of patients in every way possible. So let's look at what this transformation requires and what a practice needs to have in place to become a PCMH. So there are a number of local, state, and national PCMH recognition and accreditation programs that exist. Although some practices are required to complete a recognition program, PCMH recognition for many practices is voluntary. Now, the American Academy of Pediatrics, American Academy of Family Physicians, American College of Physicians, and American Osteopathic Association are the ones actually responsible for having developed the principles of the patient-centered medical home, but these organizations do not administer recognitions. Instead, organizations at a national level that offer PCMH recognition programs are the National Committee for Quality Assurance, or the NCQA, the Accreditation Association for Ambulatory Healthcare, or the AAHC, and the Joint Commission, as well as URAC. You want to be sure that you consider the application cost, the data and documentation requirements, and staff resources required to complete the application process when choosing which program is best for your practice, because they're all different. Now we know that several quality organizations we just mentioned offer a PCMH recognition program. However, NCQA is the most well-known program, and some consider it to have the highest set of standards. As an NCQA PCMH, certified practices meet care standards developed by the National Care Quality Association to better manage their patients' health, particularly those with chronic diseases. So from here on out, we're going to focus on the NCQA PCMH program requirements and specifics. So let's first break down the NCQA PCMH 2014 structure. It's a 100-point system, and the actual structure is composed of 6 standards. Within each standard, there are elements. 27 total elements are distributed within those 6 standards, and then within each element are factors. There are over 150 factors, to be specific, roughly around 175 or 178, and each element carries a certain point value based on the number of factors you meet in that element. And the total points for each standard varies. But the 6 standards are patient-centered access, team-based care, population health management, care management and support, care coordination and care transitions, and the last one, performance measurements and quality improvement. So we have these 6 standards, and then within each standard are a number of elements, and within those elements are factors. And the factors are what control the point value a practice receives and are what require specific documentation. But this structure will make a lot more sense when we walk through some of the elements in just a few slides, and you can actually see screenshots from the NCQA website where the scoring is actually broken down. The NCQA's PCMH recognition comes in 3 stages, with level 1 being the most basic level and level 3 the most advanced. While paper-based practices may achieve level 1 recognition, the higher levels tend to require the use of a comprehensive EHR system and at least some associated data-driven analytics, clinical decision support, or population health management features. The NCQA uses a 100-point scoring system that consists again of 27 individual elements of care, including 6 baseline must-pass elements. Practices are required to achieve a score of 50% or higher on these must-pass elements for all recognition levels, no matter what. Practices must achieve a passing grade on all 27 elements to become recognized as a level 3 patient-centered medical home. So to achieve the lowest level of recognition, level 1, a practice would need to score between 35 to 59 points. For level 2, 60 to 84 points. And to achieve the highest level of recognition, the practice must score between 85 and 100 points total. So these must-pass elements are considered the basic building blocks of a patient-centered medical home. Practices must earn a score of 50% or higher, and all 6 must-pass elements are required for recognition. So what are they? Well, we're going to go through all 6 of these must-pass elements and provide ways to show NCQA your practice is compliant with them. Keep in mind there are 27 elements, and we're just going over 6. But we will touch on each standard since, conveniently enough, each standard contains at least one must-pass element. So before we begin going through these must-pass elements within each standard, let's look at how this information is set up on the NCQA website. So if we look at this image, we can see the element title and the factors listed underneath it. Under that, we see a documentation section, which will tell you exactly what NCQA is looking for. I will not be going through the documentation section since I will provide you NextGen's recommendations on how to best meet the required documentation for each factor. And then at the very bottom of each element, we see a scoring section. And this section will tell you exactly what you need to meet each percentage. So for example, to meet element 1A, patient-centered appointment access 100%, you would need to successfully meet 5 to 6 factors, and it would have to include factor 1. Also notice at the top it says must pass and critical factor equals factor 1 in bright red. So every one of these elements I will be going over today will say must pass, since these are the ones that you have to get at least 50% or higher on in order to gain any level of PCMH recognition. But the critical factor is something different. So the critical factor is identified by its number. Here it's factor 1. Any critical factor must be met in order to receive a score on the element it is in. So let's say a practice met factors 2 through 6 for this element. They would still get a 0% or no score because they didn't meet factor 1, the critical factor. So to kind of sum it all up, when you see must pass, your practice must get over 50% for the element. And when you see critical factor, your practice must meet that factor in order to receive any credit for that element. Okay, so let's get started. Standard 1, patient-centered access. Element 1A, patient-centered appointment access. 5 to 6 factors met will score 100% on this element. And for factors that require a documented process, the process needs to include a date of implementation or revision, and it needs to have been in place for at least 3 months prior to submitting the survey tool. So factor 1, providing same-day appointments for routine and urgent care. The practice reserves time for same-day appointments for routine and urgent care based on patient preference and need. Factor 1 has been identified as a critical factor and must be met for practices to receive a score on this element. Since again, this is a must-pass element, failure to meet factor 1 will result in a denial of recognition. The practice needs a process for scheduling same-day visits for patients with routine and urgent needs and monitors the use of same-day appointments to ensure that patients are able to use this feature. Make sure you have a process for scheduling same-day appointments that includes a definition of routine and urgent appointments, and you supply NCQA with a report with at least 5 days of data showing the availability and the use of same-day appointments for both urgent and routine care. Factor 2, providing routine and urgent care appointments outside regular business hours. For this factor, make sure to provide a report showing appointments outside of normal business hours. For example, you could use the time frame from 5 p.m. to 10 p.m. Factor 3, providing alternative types of clinical encounters. So an alternative type of clinical encounter is a scheduled meeting between patient and clinician using a mode of real-time communication in lieu of a traditional one-on-one in-person office visit. For example, standalone communication or a combination of telephone, video chat, or secure instant messaging. Unscheduled alternative clinical encounters, so let's say clinical advice by telephone or secure electronic communication during office hours, does not meet this requirement. And for this factor, you will want to run the alternative clinical appointments report after creating an alternative encounter type and category in scheduling admin. Factor 4, availability of appointments. The practice has standards for appointment availability. Availability standards may be established and measured for a variety of appointment types, or the practice may set a single standard across all appointment types. One common approach to measuring appointment availability against standards is to determine the third next available appointment for each appointment type. The third next available appointment measures the length of time from when a patient contacts the practice to request an appointment to the third next available appointment on the clinician's schedule. So run the first third available appointment report to show availability of appointments. Factor 5, monitoring no-show rates. To provide consistent access and help understand true demand, practices monitor no-show rates. You can prove this by running an appointment listing report and filter for no-shows in EPM. And finally, factor 6, acting on identified opportunities to improve access. This will follow the plan, do, study, act cycle, which we will go over in a few slides for a different standard. Standard 2, team-based care. Element 2D, the practice team. The practice provides continuity of care using culturally and appropriate team-based approaches. You must meet all 10 factors to receive 100% on this element. There's unfortunately no wiggle room here. So some options to prove you are meeting these factors are factor 1, defining roles for clinical and non-clinical team members. NCQA is looking for job roles and responsibilities that focus on team-based approach to care, and the documentation you should provide them should be job descriptions that include staff responsibilities and functions. Factor 2, identifying the team structure and staff who lead and sustain team-based care. Really, again, NCQA is looking for how a practice defines care teams and how they align to provide patient-centered care. So go ahead and provide an organization chart or an accountability chart that shows team structure. Factor 3, this is a critical factor, meaning again, you have to meet this factor to get any points for this element. Having regular patient care team meetings or a structured communication process focused on individual patient care. These meetings may just be informal daily gatherings or reviewing daily schedules. A structured communication process can be regular emails, tasks, or messages about a patient. You want to provide samples of communication such as chart notes, appointment notes, regular email exchanges, tasks, or a sample of meeting notes. Factor 4, using standing orders for services. This is pretty self-explanatory. Just provide a screenshot or a written standing order that is in place at your practice. Factors 5, 6, and 7 all go together, and they're training and assigning members of the care team to coordinate care for individual patients, to support patients, families, caregivers in self-management and behavior change, and to manage the patient population. These all focus on training of staff, which includes training new staff and retraining current staff for things like cross-department communication, patient coaching, and population health management. For each of these factors, providing an updated description of positions and roles and responsibilities associated with them is recommended. Factor 8, holding regular team meetings and addressing practice functioning. This is essentially the same as Factor 3, but this addresses all patients, not just a specific patient. For this one, you could supply meeting notes, a meeting calendar, memos, or a meeting agenda. This documentation should show discussion on methods of care that are working well, which ones may not be working well, and what needs improvement. Factor 9 and 10, involving care team staff in the practice of performance evaluation and quality improvement activities, and involving patients and their families in quality improvement activities. Both are really looking at how the team identifies areas of improvement and that the staff, as well as patients and their families, are playing a part in quality improvement. For these, you'll need to provide documentation of a process used to involve everyone in quality improvement efforts. Managing patient care is a team effort that involves clinical and non-clinical staff. The emphasis is on ongoing interactions of team members to discuss roles, responsibilities, communication, and patient handoffs, so everyone can work together to provide enhanced care to the patient. Standard 3, population health management. Element 3D, use data for population health management. This element encourages increased access to your patients to your clinics regarding appointments. So practice must meet 4 to 5 factors total to get 100% on this, and you can only meet 3 factors and still get 75%. At least annually, the practice proactively identifies populations of patients and reminds them or their families of needed care based on patient information, clinical data, health assessments, and evidence-based guidelines, including, for Factor 1, at least 2 different preventative care services. So for this, a practice could run a report for 2 different preventative care services with an applied filter for patients who have never had these services in the correct age range. An example would be a colonoscopy or a mammogram. They may also use the Population Health Management Hub to do this. Factor 2, at least 2 different immunizations. A practice may run a report for at least 2 different immunizations for patients who have never had them in the correct age range. Factor 3, at least 3 different chronic or acute care services. Factor 4, patients not recently seen by the practice. So for this one, running a report for patients due for an appointment, such as a well child check. Factor 5, medication monitoring or alert. So running a report for patients on a medication that requires a follow-up and haven't been seen. For this, you can run a report on the last encounters in the past 6 months based on a specific medication. An example would be a patient on Coumadin who hasn't been seen yet this year. As you can tell, these factors will mostly focus on generating lists of reports regarding services needed for your patients, and then sending reminders to your patients to come in and get those services. So your practice can provide screenshots to prove you are meeting these factors or copies of the reports. All right, Standard 4, care management and support. Element 4B, care planning and self-care support. A practice must have 75% of patients to meet each factor, and they must meet all 5 factors to have 100% for this element. So the care team and patient, family, or caregiver collaborate to develop and update an individual care plan that includes the following features for at least 75% of patients. So incorporating patient preferences and functional lifestyle goals, as well as identifying treatment goals. For both of these, you can go into the patient care plan in the goal field, and you can select either of these as a care plan item and run a report showing percentage of patients with this selected. Factor 3, assesses and addresses potential barriers to meeting goals. In the patient chart note, there's actually a barriers to care section, and this can be filled out, and then a report can be run showing the percentage of patients with this included in their chart. It includes a self-management plan. Under education and recommendations in the patient note, the user is actually able to check self-management discussed. And Factor 5 is provided in writing to the patient, family, or caregiver. So in the patient chart, you can actually select care plan given to patient, family, or caregiver, and then again, run a report to back up your data. Standard 5, almost through these must-pass elements. I know there are a lot to go through. Care coordination and care transitions, element 5B, referral tracking and follow-up. A practice must meet Factor 8 in order to receive any credit for this element, and they must meet between 9 and 10 factors in total to get 100% for this element. Overall, element 5B is really providing proof that the practice systematically tracks, tests, and coordinates care across specialty care, facility-based care, and community care. Really, there's 10 factors here. Going through all of these would be a lot. Just to touch on the critical factor here, that's Factor 8. And this is tracks referral until the consultant or specialist report is available, flagging and following up on overdue reports. So for this one, you would provide a screenshot of your order details template for a referral and make sure to highlight the ability to check when it was received, completed, or canceled. The user can then run a report based on this criteria as a filter. Now, on to our last must-pass element under Standard 6, Performance Measurement and Quality Improvement. We have element 6D, Implement Continuous Quality Improvement. All 7 factors must be met to achieve 100% for this element. And this one really is different from all the ones we've looked at. It's looking at how the practice uses performance data to identify opportunities for improvement and acts to improve clinical quality, efficiency, and patient experience. The practice uses an ongoing quality improvement process to set goals, analyze a practice function, and improve on that function. I won't go through each factor again specifically, but that's the general idea for each of the 7 here. To meet this, the practice may participate in or implement a rapid cycle improvement process, such as a plan, do, study, act, or a PDSA cycle. A PDSA cycle represents a commitment to ongoing quality improvement by setting goals, analyzing potential barriers, and planning ways to get around those barriers. The important thing here is that the practice is setting clearly defined goals and is taking actions to improve performance. NCOA is really looking to see if there's a regular evaluation of performance data against the goals you set. Okay, so we made it through the 6 must-have elements, and that was the hardest part really to get through, and it was really just to show you how much is involved in this PCMH transformation. So there are a lot of good things to be said about the PCMH model. It's been credited with reducing healthcare costs, boosting the delivery of preventative services, and improving care coordination. But transforming the average healthcare organization into a PCMH and achieving the official designation can be challenging, as we just saw firsthand going through those 6 standards alone. So why should providers consider the PCMH model, and what barriers might stand in their way? Well, let's start with common reasons why. First off, this industry shift. Healthcare in the United States is moving away from volume-based payment toward a value-based system. Given the state of the marketplace today and the rise of value-based care initiatives holding providers accountable for cost, quality, and patient experience, this is a great way to make sure your practice will be successful in this shift. Second, cost reduction. There's mounting evidence that the PCMH is effective for reducing costs through better care coordination and improved data exchange. Population health management. Ensuring high-quality care. Increased reimbursement. PCMH accreditation often is required to obtain an increase in reimbursement from a health plan. PCMH recognition programs are optional, but many commercial insurance plans and state Medicaid programs provide additional incentive and financial rewards to practices that have achieved PCMH recognition. Some example of incentives include compensation for care coordination per member per month, performance-based care based on achieving improved quality and efficiency goals, and traditional per-visit fees to ensure patients are seen for preventative care. And lastly, better overall reputation. PCMH recognition signifies that a provider has become an advanced primary care practice. Let's look at the benefits your patients will experience. Who doesn't want happier patients, really? Another part of the PCMH transformation involves measuring patient satisfaction. And for many providers, one of the keys to increasing satisfaction is expanding the access patients have both to their doctors and their own health information. It's also known that patients participating in the PCMH program receive more preventative screenings and pertinent tests than others as a result of better, coordinated, more comprehensive, personalized care. This is because PCMH puts a greater focus on individualized care and more accountable population health management. This leads to improved health outcomes, especially for patients with chronic conditions. Benefits for the practice. As for practices, you will also see increased physician and staff member satisfaction, improved safety and quality of care, a more efficient use of practice resources resulting in cost savings, opportunities to participate in payment incentives for adopting the functions of a PCMH, better prepared to succeed once primary care payment reform has become widespread. So we're talking about value-based payment again. And finally, they will also be better prepared to participate in accountable care organizations. So we have all of these great patient and practice benefits, but what's holding docs back then from doing this? Well, like I said before, obtaining formal PCMH recognition is not required, and there are significant reasons practices may choose to forego this certification. The first being gaining patient and physician buy-in. The first step is one of the hardest, turning reluctant patients into engaged partners in their own care. Challenge 2, creating the necessary health IT infrastructure. Creating a robust health IT infrastructure requires significant financial investment and strong buy-in from leadership and clinical staff. It's no secret that achieving a fully integrated, interoperable, effective health IT ecosystem with all the bells and whistles of clinical decision support and predictive analytics can be difficult. It's also very expensive. Providers may wish to invest in infrastructure a little bit at a time, which may make good money sense, but it may also drag out the process for longer than is desirable. Challenge number 3, the recognition process itself. Achieving recognition takes dedication, time, and teamwork. The requirements for recognition honestly can be a stretch for some organizations. A total PCMH transformation can take well over a year. And you're looking at a pile of documentation and reports that need to be collected and reviewed. And finally, one of the biggest challenges is cost. Cost to set up and maintain a patient-centered medical home is substantial. But let's look at the cost and the return on this investment a little more. So what is the cost? It does cost money to do this, in labor associated with staff, the cost of technology, such as an electronic health record and patient portal, and the opportunity cost. Many practices find they need additional support, not just for the work of compiling application materials for PCMH recognition, but also to implement new workflows that result from practice transformation. Practices should also consider the expense of potentially spending more time with patients. If you're practicing patient-centered medical care, you're running a continuous improvement lifestyle type visit, and that takes time. The investment required to acquire technology tools and implement new care strategies could seem overly daunting to many primary care organizations. The fact that it could take several years to see a return on this investment may also give providers reason to avoid this. However, those that do commit and take the leap can see positive results. Even in 2015, direct payer incentives for becoming a PCMH range from none to as much as 30% increase in reimbursement across the board. The landscape is constantly shifting. One example published in a recent study is Guiding Your Health System's Patient-Centered Medical Home. Their PCMH initiatives produced a 7.9% total cost savings, which translate into an average of savings of $53 per patient per month in each care site. They had savings on acute inpatient care, which dropped by 19%, and approximately 84% of provider panels earned outcomes-based incentives averaging more than $40,000. So it can be expensive, yes, but all the research supports the idea that the PCMH recognition is a very effective cost savings program. So if we look a little deeper at the statistical evidence and focus on the Patient-Centered Primary Care Collaborative, or the PCPCC, they released an annual report that indicates the PCMH is improving costs, utilization, access, and satisfaction. Of the 28 reports serving as evidence in the annual review, they found that 17 found improvements in cost, 24 found improvements in utilization, 11 in quality, 10 in access, and 8 found improvements in satisfaction. ED visits, preventable hospitalizations, and the use of urgent care instead of primary care services all fell in many of the projects, while patient satisfaction scores rose significantly. Another PCPCC report found that 21 out of the 23 studies that included data on spending saw cost reductions, while 23 out of the 25 reports that measured utilization saw improvements on one or more measures. This comprehensive review and evaluations of existing PCMHs shows that the majority of programs can reduce spending in one or more categories, decrease improper utilization of services, and prepare providers for a smoother transition into a value-based reimbursement model. The PCMH continues to show staying power as one of the healthcare industry's most effective cost-cutting and quality-boosting initiatives. It really does work to control costs and promote the right care for patients. So I'm sure many of you are wondering, what is the actual recognition process like? Let's first look at some essentials a practice needs to become a PCMH. First, having a plan in place is key. Second, strong leadership and staff commitment. The most important key for success is a strong commitment to the overall transformation. Securing executive buy-in and clinician engagement is an important step for the process and can be a critical part of the successful transformation. And underlying technical infrastructure, which we'll talk more about next. Effective patient engagement tools, think the patient portal. And community stakeholder buy-in. Community connections provide the foundation for a truly effective PCMH. Primary care providers can no longer work in isolation, sending patients out to specialists but rarely receiving feedback on the results. So if we focus on one of the 5 essentials to becoming a PCMH, specifically the technical infrastructure, a big part of that is the EHR. The technology that supports the medical home starts with the EHR, which should include a registry function to search for a series of demographics. You need communication systems to inform patients, remind them, teach them, and encourage them. You also need a communication system within the practice so that the care team can meet regularly to share data. You need the ability to track and document what you've communicated and collaborated on. By implication, a PCMH must be able to give patients information and data about themselves. That could take the form of a printed report, or for the more tech-savvy patient, a personal health record that could be accessed and distributed electronically. In addition, a key PCMH condition specifies the ability to open your practice for extended access by patients. That may be addressed by a scheduling system or a portal through which patients can communicate with the practice. So that's a lot to have in place before you even begin the transformation process. But once you're ready, you should first look at your eligibility. The PCMH program is for practices that provide first contact, continuous, comprehensive, whole person care for patients across the practice. A PCMH is not an institution, a nursing home, or a home health agency. It's a medical office or a clinic that offers coordinated, comprehensive primary care that is personal and focused on making sure the patient's healthcare needs are met. If a specialty practice can demonstrate that it provides whole person care and meets the other elements of the joint principles for most of its patients, it can be eligible for PCMH recognition by NCQA, even if it's not a traditional primary care practice. The NCQA certifies by reviewing evidence provided by the practice through an application process. Instead of accreditation, the organization prefers the term recognition to describe the PCMH certification that it awards. So where do you start if you haven't already began preparing for the PCMH model? Well, first you obtain the electronic survey tool. This tool is $80 and it can be ordered through the NCQA's website or by calling their customer support. Then you do a self-assessment of your practice's current performance. This will take approximately 6 to 9 months, and the process will vary among practices depending on the work required during the practice transformation. Once that's all done, you're going to go ahead and submit your information to NCQA. That includes your application, your agreement, your fee, and your results. Then you receive recognition from NCQA. Once your information is received, your practice will receive the final recognition decision and corresponding level within 60 days. Remember, there's 3 different levels. The recognition lasts 3 years, so you want to make sure you maintain recognition by completing the renewal process at least 6 months prior to expiration. I did want to point out there have been some NCQA program revisions. As of March 24th, 2014, a new version of PCMH was released, retiring the PCMH 2011 model. The last day to submit PCMH 2011 was March 31st of last year. So everyone should be up to date and on PCMH 2014, but I just wanted to point out that in case anyone wasn't aware. And finally, if we don't just look at NCQA recognition, in general, each certification process involves a set list of standards provided by the certifying body, followed by an assessment and an application. I did go ahead and include this chart just to give an idea on the cost for NCQA recognition. And specifically, you can see the initial fee for obtaining the survey tool license is fixed at $80 for everyone. And then application fees just depend on how many providers you have at your practice. So I know I already went over the cost of becoming a PCMH, but it can be expensive, especially up front, but the cost savings that can come from it have also been proven very beneficial. Now, PCMH prevalidation and NextGen. So as we know, the NCQA PCMH recognition program is the most widely used for achieving PCMH practice transformation. Well, NCQA offers pre-validation for EHR vendors to assist clients in achieving points toward recognition. NCQA's pre-validation program evaluates EHR systems, advanced registries, population health management tools, and other related technology solutions to identify alignment with PCMH standard requirements. For IT vendors, vendors of PCMH pre-validated products have successfully demonstrated their technology solution that it has functionality that completely meets one or more factor level requirements within the PCMH standards. The evaluation can result in approved automatic credit, also called auto credit, that are transferable to eligible client practices submitting for PCMH recognition. So auto credit, basically it awards automatic points to a practice after using pre-validated software. Remember, the NCQA recognition is out of 100 points. So this would really help providers in achieving that. For practices that use PCMH pre-validated products will benefit from reduced documentation support, saving time, and alleviating some of that administrative burden associated with meeting PCMH survey requirements. Just to name a few of the benefits are participating in pre-validation, the biggest being the ability to transfer auto credit scores to eligible client practices. Again, alleviating the administrative burden of providing documentation support for those factors approved for auto credit. The ability to communicate direct alignment of product functionality to NCQA establishes an ongoing collaborative relationship with NCQA and gives vendors frontline details about planned policy changes and enhancements to PCMH recognition program requirements, and offers a competitive edge with marketing support. So why do we care about this? Well, on January 12th of this year, NextGen gained NCQA PCMH 2014 pre-validation. Clients may benefit from reduced documentation and have scoring associated with awarded auto credit applied to their total PCMH 2014 survey score. NextGen Ambulatory EHR has been awarded a total of 17.87 points in PCMH 2014 auto credit. So that's almost 18 points out of 100 you don't need documentation for if you're a NextGen user. Now, practices that want to use auto credit for the PCMH survey should do the following. Step 1, obtain the NCQA issued pre-validation summary approval table, and that's what you see on the screen, the NCQA letter of product auto credit approval, as well as the letter of product implementation from the vendor, indicating which pre-validated tools or modules approved for auto credit have been implemented at the practice. Step 2, complete an application and enter in required agreements for the NCQA recognition program. Step 3, upload all the documents obtained in Step 1 into the organizational background section of the ISS survey tool. And you can actually access all of these required documents from this link. It takes you to the PCMH page in the NextGen Success community. And Step 4, in the organization background section under pre-validation tab of your ISS survey tool, complete the site attestation under question 2B by checking the box. By doing so, you attest the implementation and use of an NCQA pre-validated health IT solution for associated auto credit points, as specified in your attached NCQA pre-validation summary approval table. And Step 5, submit the survey tool. Clearly, NextGen's EHR works well for PCMH clients, and actually 30% of PCMHs recognized by the NCQA are using NextGen solutions. That translates into more than 2,300 NextGen healthcare providers who've achieved levels 1, 2, and 3 patient-centered medical home recognition. NextGen actually supplies this image, and I think it really does provide a good overview of what's expected from a practice at each phase of the transformation. You have these 5 core attributes, which we've heard a lot today: comprehensive, accessible, coordinated, committed to quality and safety, and patient-centered. And we also have these 6 goals nicely outlined. This image really is a great tool to summarize the journey to becoming a PCMH, and it offers a high-level view at what a practice will need to do. Now let's look at PCMH in the future. And for this last section, I'm going to actually turn it over to Kathy Thompson to lead us through this. Kathy?
Good afternoon, everybody. PCMH and Meaningful Use. The Patient-Centered Medical Home, PCMH 2014 Recognition Program was developed to align with Meaningful Use Stage 2. Alignment has been updated to reflect the Meaningful Use Modified Stage 2 final rules released in October 2015. Below is a list of the PCMH elements and factors that directly align with meaningful use objectives. As you can see, there are multiple that align both PCMH and meaningful use. PCMH and MACRA. Healthcare in the United States is moving away from a value-based payment system and toward a value-based system. PCMH transformation will allow your practice to have a better position to respond to this challenge. Focus is on PCMH, ACOs, and bundled payments. The merit-based incentive payment system, otherwise known as and better known as MIPS, created by MACRA, promotes the PCMH as a promising, innovative care model that can accelerate the transition towards a comprehensive value-based care ecosystem. Starting in 2019, practices that certify as a PCMH will be able to reap the benefits of Medicare's new alternative payment model program by receiving a 5% pay bonus while avoiding the downside risk usually associated with value-based payment models such as accountable care organizations. Uncertain where your practice stands? Let iTenib help. We can assess your current readiness, provide recommendations, implementation of new processes and procedures with our assistance. Next steps. Visit us on the iTenib website, itenib.com. Sign up for our informative webinars and blogs. Consider our 3-day fixed price on-site consultations, clinical workflow, revenue cycle and front office, technology and performance. Test drive some of our products. Resources. Available in this webinar, which will also be available on our website, is the resource to the NCQA PCMH Recognition website and the NextGen PCMH resource page. And now we will begin opening up the line for questions.
Hey ladies, thank you so much for all that information. Great job. As a reminder, you can ask any questions in the GoToWebinar control panel just by typing them in. I see a couple of people have their hands raised, so if you have questions, just go ahead and type them. Otherwise, I'm going to guess that they're accidental hand raises. Okay, so first question. It stated that you would run a report showing appointments between 5 and 10 p.m. for after-hours access. Don't weekends count as well?
Yep, access weekends count as well. It's just outside normal business hours. So weekends would count. 5 p.m. to 10 p.m. was just kind of an example that you wouldn't be running runs from 8 a.m. to 5 p.m., for example. But yep, weekends would count.
So any after hours basically that they're there for. Okay.
Yeah,
Thanks,
basically
Lindsay.
to meet the requirements for this factor, just kind of go through it. You have your regular business hours, and the intent of that factor is just providing appointments outside of the regular business hours. So again, NCOA does not prescribe specific regular or extended hours. You just have to establish your own. All right, now I'm done, Chelsea.
Yeah, okay, thanks, Lindsay. Next question. Are practices required to provide a minimum number of same-day appointments for the NCQA recognition?
Nope. NCQA does not require a minimum number of same-day appointments per day, and not all clinicians must offer same-day appointments. So practices just have to have a written policy or process for staff to ensure the availability of same-day appointments and how many patients get them. And that's when it comes in key. Basically, you have to provide a report of at least 5 days of availability of same-day appointments, and that's what NCQA is really looking for. But there's no minimum specified.
Thanks, Lindsay. Next question. For PCMH 4 element B, do we capture the data from the care management templates? Kathy, maybe you want to take that one? Kathy,
go ahead and repeat that. Go ahead.
Yep,
I'm unmuted now. Sorry about that.
Okay.
Go ahead and repeat that one more time.
Yep. For PCMH 4 element B, do we capture the data from the care management templates?
If you're using the care management templates, you can capture some of that data from element B, yes. Not everybody uses the care management templates, but if you are using it, then definitely you can use that towards that.
Thanks, Lindsay. Next question, and it looks like this is the last, so if you have any questions, feel free to type them in. Otherwise, you have all the information for contact information up here on the screen. So the question, what's the difference between a must-pass element and a critical factor?
I can grab that one. First off, this is actually a good reminder for everyone on the call, the structure of the NCQA recognition. Let's go over that. So there's 6 standards, and within each standard are elements, and then within each element are factors. So a must-pass element is what the practice must achieve at least a 50% score on, and there are 6 of those, and those are the 6 we went over. And then within those elements are factors, and a critical factor, which is identified at the beginning of the section, must be met for practices to receive a score on that element. But something to kind of point out here, if you have a critical factor inside of a must-pass element, you have to meet that critical factor to receive any score on that element, which depends on recognition. So, but just remember, factors are within elements.
Okay, thanks, Lindsay. As a reminder to everybody, you can always ask us any questions either with the contact information you see up here or on social media. We're on Twitter, Facebook, LinkedIn. Follow us on those. We always share tech tips and NextGen news and all sorts of industry-related information. So follow us, and I'll be sending out a follow-up email later this week with a link to the recording as well as the slides if you'd like to download those. Kathy, Lindsay, thank you so much for sharing some great information today.
Yes, thank you, everyone. I know it was a ton of information to work through, so thank you again.
Well, thanks so much, everyone, and have a great day.